Okay, let's start the session here. You all understand this is the refractive surgery update session, rapid fire. The presentations are supposed to be of 5 minutes, so please complete before that, so that we can have a few question answer discussions. And I hope everybody will join subsequently also. In the meantime, people who are sitting here, you are free to ask questions after the presentations are over. So let me invite the first speaker, that is a comparative study of change of corneal curvatures and uncorrected distance visual acuity prior to and after corneal collagen cross-linking, a one-year result. Chief presenting author is Nader Nasiri. Just now, the person is not there. I think Basit Ali Lakhani is also not here. We're going to go to third presenter, that is Karen Ike. Ike? AJ. Karen AJ Semis. So this topic is residual refraction correction after LASIK by adjusting corneal Q value with SMILE module. Okay. You can start.
Okay. Residual refraction after LASIK is a common cause of postoperative patient dissatisfaction. And in our study, our purpose was to investigate long-term efficacy, safety, and corneal changes after fresh lenticle transplantation to treat post-LASIK hyperopic residual refraction. So why did we prefer this procedure? Because it preserves accommodation and it's reversible. The lenticle can always be explanted when needed. And also it's ideal for patients who do not have cataracts. In this retrospective study, we included 64 eyes of 32 patients, 18 male and 14 female, and all patients were followed for at least 1 year. And the study was approved by the National Research Ethics Committee of the Ministry of Health of Kosovo. And our inclusion criteria were that patients were at least 18 years old and they had already undergone LASIK surgery and had residual hyperopic refraction. And their pre-op corrected distance visual acuity was at least of 0.5 logmar, and they were willing to undergo this procedure. And the exclusion criteria was the presence of any active infection, history of glaucoma, retinal detachment, and if the estimated postoperative corneal thickness after the surgery exceeded 650 microns, we excluded these patients from the surgery as well. Our patients were aged between 38 to 55 years, and their hyperopic residual refraction was between 0.75 to 2.75 dioptries, and the donor patients were aged between 20 to 28 with lenticle thicknesses ranging from 25 to 70 microns with dioptries between minus 1.25 to minus 3.5, and with optical zone between, in average, 660 microns. And when we were matching recipient corneas with donor lenticles, we paid attention to the mesopic pupil size of the recipient patients, and the transplanted lenticles were calibrated to exceed the diameter of the mesopic pupil size by at least 0.5 millimeters to avoid any possible problems at night vision. And in this surgery, we did not touch the flap. We made an incision at the depth of 140 microns instead. And our postoperative refractive target was minus 0.5 dioptries in this surgery. And the lenticle was transplanted centrally. And this is a pre-op and a post of 1 year of CT. And the uncorrected distance visual acuity, corneal thickness, K values, and RMS values increased postoperatively, and the Q value decreased postoperatively from negative 0.38 to negative 0.70, and the uncorrected near visual acuity at 80 centimeters improved from JAGA 6 to JAGA 3, and at 40 centimeter improved from JAGA 7 to JAGA 2 postoperatively. And the surgical technique alters corneal geometry by modulating the Q value, thereby enhancing corneal sphericity and improving visual acuity at far, intermediate, and near distances. And this could be a possible alternative treatment in the future, but such studies are needed to back up our results. Thank you.
Thank you so much. It is a very interesting series of cases post-LASIK hyperopia. And you did a smile in these cases and a hyperopic smile in these cases to take out the lenticule from there. Was there any difficulty because you already had a LASIK flap? And how did you create the, your this lenticule? What are the depth? Because you had to, you can't take out from the flap. What was the flap thickness in these cases?
The flap thickness was at 110 microns, and that's why we made the incision at 140 microns underneath the flap.
Okay. So you had a deeper initiation. Were there these were femtosecond laser flaps or microkeratome flaps initially, LASIK?
Could you please repeat?
The LASIK procedure they have undergone,
Yes.
was it with the femtosecond laser or was it because, due to the microkeratome? You can make a flap by microkeratome also, you can make a flap with the femtosecond also. So these are femtosecond flaps or microkeratome flaps?
We made an intrastromal pocket
No,
instead.
no. Before you made an intrastromal pocket, the previous surgery.
The previous surgery was not done in our center.
Okay, they are all referred cases.
Yeah.
So you can have, if it is a microkeratome flap, it will be thicker, then you have a very little stroma left to create the lenticule. But results are quite good in these cases. Okay. No difficulty you face, no complications?
No, in this series, no.
Okay. Any one question from the audience? Okay, thank you so much for your presentation. Let's go to next topic, that is on the management of residual refraction after trifocal IOL implantation using SMILE surgery. The chief presenting author is Dr. Faruk Semiz.
Hello, my name is Dr. Faruk Semiz. I am from Turkey. Management of residual refraction after trifocal IOL implantation. Why carry out this study? Residual refraction is one of the biggest causes of postoperative patient dissatisfaction after cataract surgery. This study aimed to provide evidence to support SMILE as an alternative and comfortable option both patients and surgeons for improving both the visual outcome and patient satisfaction. This study published Ophthalmology and Therapy 22. This study includes 82 eyes, cataract surgery with size trifocal IOL implantation, underwent cataract surgery at various clinics between 2017 and 2018. YAG laser capsulotomy with or without posterior capsule, opposite 3 months after cataract surgery. SMILE surgery was performed 1 month after YAG laser surgery. Patient with hyperopia less than 23 millimeter axial length. The patient had residual myopia between -1 and -2, 25 dioptry, astigmatism -0.75 and -1.75. Excluded patient with history of high myopia and pre- and postoperative evaluation we did mesopic and photopic condition. This is a SMILE surgery, pseudophag patient. And intrastomal pocket we prepare first, and cup thickness, every time I use 130 micron. Femtosecond laser support energy, 130 nanojoule. 1 minute take for me, easy. For this reason, I use this procedure. Results, and Q value increase 1 year after, and visual acuity increase. Pre- and postoperative RMS and Q values. Post-op RMS decrease, Q value increase. Near visual acuity. In this study, we benefited from this feature of the trifocal lens and increased distance and intermediate vision ratio without compromising the comfort of near vision. The study highlights two important concepts. Success was achieved by maintaining a balanced approach, avoiding excessive increase in the Q value and preventing excessive reduction in total RMS. SMILE technique is a safe and effective treatment modality for certified myopic fracture to improve the visual outcomes and satisfaction of patient after cataract surgery. Thank you so much.
Thank you so much for this presentation. Just one query. I think you said your patient would have undergone YAG capsulotomy maybe after 3 months of surgery.
Yeah.
And after 1 month of YAG capsulotomy, you went for a SMILE in these cases.
Yeah.
That means approximately 4 months after the cataract surgery. Why didn't you do it before YAG capsulotomy? Why did you do YAG capsulotomy in these cases?
10 years ago, I started.
Because they had a significant residual error of ranging from minus 0.75 to 2.75 diopters. And YAG laser, I don't know why you have done a YAG capsulotomy in this case.
10 years ago, I started this procedure. First, I start not include this in the no YAG laser did. And after that, some residual refraction coming in the, for the season, and I do YAG laser.
So what was the smaller refractive error, that lowest refractive error you have corrected in this?
Normal SMILE surgery, no different.
Lowest, -1, -0.75.
This I start minus 0.75 small and high.
Because you have used Vizumex 500 in this particular case.
Yes, yes.
So you are comfortable using this system for a -0.75 because lenticule will be very thin.
Yes.
You are comfortable there? To remove the lenticule sometimes
Yes.
can be very tough if you have a very thin lenticule. Because
No.
0.75 is a very small
Yes,
myopia.
very small. No problem for me. Every week I do this procedure.
And you had quite a significant cylinder also, range from
Yes.
0.75 to 1.75 diopters. Do you think 1.75 is can be corrected with a SMILE procedure, or you would have done other procedure?
Yeah, no problem for me.
No problem.
No
Okay.
problem.
Any questions? One question from the house. This is an interesting series of cases. Post-cataract surgery, trifocal lens, Zeiss Ateliza has been put. After that, they had a significant residual refractive error, which you all know can be corrected by various procedure. It can be PRK, LASIK, or SMILE now. And yes, one question.
I have a similar question which I don't get answer to.
Yeah.
YAG with the PCO is okay, but YAG without a PCO, I mean, why was YAG done even if there is no posterior capsule operation?
If I understand, his answer was even once you do a YAG capsulotomy, there may be some refractive error coming up because maybe because the lens effective lens position might change. So it is better to do a refractive correction after whatever happens, then you do a refractive correction. Yes, that was his idea. So that opens the posterior capsule, which is not very good idea sometimes, especially a multifocal, trifocal lenses, because we tend to blame the posterior capsule for sometimes the complaint for a patient, and we open the posterior capsule sometimes without any necessity. But it's a good concept. Thank you very much for your presentation. Let me again narrate the first two speakers if they are here. Dr. Nadir Nasiri. You can sit down, sir. You have second presentation also, no? And Dr. Basit Ali Lakhani, not here. So I request again, to present his second talk, second presentation, Dr. Farooq Shamis.
Successful treatment of hyperopia and presbyopia lenticule
Can I have the
transplantation
presentation, please? Yeah.
with SMILE surgery. To investigate the improvement in distance and near visual acuity in hyperopia and presbyopia patient after myopic lenticule transplantation, focusing on corneal shape modification to ensure a treatment efficacy without complication by lenticle transplantation. Promising alternative, reduced regression risk for hyperopia compared to conventional methods. Enhanced correction, adding tissue instead of removing it reduces corneal instability and enhances correction for high hyperopia. Reversible, the lenticle can be removed if needed. Ideal for specific patient, young patient with hyperopia and presbyopia who don't cataract. We did examination, probe, and post-op mesopic and photopic condition. This study includes total 30 patients, total eyes 40 eyes, patient with 2 eyes, presbyopia and hyperopia 10 patients, patient with 1 eye, treat hyperopia 20 patients, and age range 20 to 50 years. Inclusion and exclusion criteria, spherical hyperopia +3 to +6.50 diopter, astigmatism +75 to +1.75, corneal thickness 400 micron to 550 micron. This is important. After transplantation, corneal central thickness over than 650, big problem. Endothelial problem and overcorrection problem. For this reason, this is limitation, this study. And this operation, mesopic pupil size, very important. Donor lenticle size was set to be 0.5 millimeter larger than the recipient's mesopic pupil size for driving in the night. And the target postoperative refraction was minus 0.50 diopter. Operation 1-2 minutes for me, very easy. 1 hour after, patient satisfaction started. Visual acuity increase, corneal central thickness increase, and Q value decrease, total RMS increase. Visual acuity increase, and postoperatively uncorrected near visual acuity 35 centimeter was Jagger 7, which improved to postoperatively Jagger 2. Similarly, preoperative uncorrected near visual acuity 70 centimeter was Jagger 6, and postoperatively uncorrected near visual acuity Jagger 3. Corneal topography, pre-op and post-op, total RMS, this increase, Q value, you can see, before operation minus 0.34, post-operatively minus 0.69 decrease. Pre-op and post-op photopic and mesopic condition, binocular reading speed 100 watts, post-operative increase. Questionnaire results, all patients completed questionnaires before and after surgery. Reading satisfaction postoperatively, computer use, and night driving satisfaction increase. This study reports 1-year follow-up data of patients with hyperopia and hyperopia with presbyopia, no rejection or complication. These results suggest that this method can effectively treat both distance and near vision, but future studies are needed. Thank you so much.
Very nice presentation, Dr. Farooq.
Thank you.
Just one query. You have taken the SMILE lenticule
Yes.
and transplanted into the patient's eye. So you had a wide range of refractive error ranging from plus 0.75, plus 3 to plus 6 diopter in your patients. So how did you fashion out the SMILE lenticule for these patients? Because your outcome was very fantastic, 0.5 diopter plus, and most patients were there. So how do we manufacture or customize this lenticule to suit these patients? size you said rightly, it should be 0.5 millimeter than the myopic pupil size. That is
Yes.
good. But taking out this lenticule, because no, smile lenticules can be very difficult to sometimes implant, because they're very thin and you can say very elastic also. So how did you fashion out the lenticule? Are these lenticules from all those patients undergoing smile patients,
Yes,
or you fashioned out separately for your hyperopic patients?
Yes. Before every week I do this procedure. Fresh lenticule I use, no bank use. We have not corneal bank for the season. I have to use.
So suppose
for
you have
example-
a patient of plus 6 diopter
Yes.
hyperopia. So which lenticule you'll prefer?
Myopic 6.50 diopter.
Okay, I think that has to be specified in this.
Yes, yes. Minus 0.50 target dioptry I focused.
Do you treat this myopic lenticule to create the hyperopic aspheric design
No.
with the laser application?
No, I take fresh lenticule. For example, before.
So this is not an actual titration. This is just putting the lenticule and hope that this will correct your hyperopia.
Yes.
It cannot be actual foolproof method to correct the entire range of error. So this is just adding a lenticule. And we have seen that all these stromal lenticule which we implant in the pocket, initially the thickness may be 50 to 80 microns. But if you see these patients after 1 year, the thickness of lenticule may be just 20 microns or 30 microns. Because of keratocytic activity, the thickness
Yes.
goes down.
Yes.
Effectively, your correction also will go down at that time. So that also should be assessed in these patients. Any questions? Yeah, please.
Hello, I have the question about your inclusion and exclusion criteria about axial length of the eye. Did you include it?
Exclusion criteria is important after operation corneal central thickness 650 and up problem start, and overcorrection start, and endothelial problem start. And the other exclusion criteria have to donor lenticule mesopic pupil size bigger than recipient pupil size. Patient coming, yes, all day good, but night driving, big problem coming. When I start 10 years ago, first patient, I have to change lenticule. So for the season, every time this presentation, I say mesopic pupil size very important, and corneal central post-op corneal central thickness 650 and up, big problem. This is very important. The others, no problem.
I think the smile lenticule which we would have is that will range from the 5.8 to 6.5 max. You can't make it bigger than that. So if your myopic pupil size is bigger than that, you don't have the smile lenticule. So that's why it cannot be customized per se.
Yes.
And the myopic lenticule which we extract, I'm not sure it's actually going to correct the hyperopia in a perfect manner. It's just adding the onto the corneal thickness and changing the refractive index of the cornea and making a little bump in the central area which might correct the hyperopia in these cases. So that's a hyperopic. People have designed the stromal lenticules and ablated the lenticule to correct the hyperopic, because if you look into hyperopic correction, the center to periphery design has to be changed. It's not like a myopic lenticule. So that needs to be reassessed in these cases. And only thing is, this can be reversible procedure. If the lenticule doesn't work out, you can take out. The complication which you can have, you can tear the lenticule when you are pushing inside. It may not spread correctly. Once you go inside the pocket, nothing is visible. It's very difficult to visualize. And many people would dilate the pupil so that you can see the peripheral areas and you can flatten the lenticule properly in these cases. Or many people use other dyes, like you can inject fluorescein inside the pocket. That gives a visibility. Even a triamcinolone can be injected to see the visibility of lenticule, which is spread correctly or not. Or you take the patient immediately to antersegment OCT and see the ideal position and shape of this lenticule. You can then inject some epithelial cells, and epithelial ingrowth can be one of the long-term complications in these cases also. But it's a new concept. Thank you so much,
Thank
and
you.
thank you coming from Turkey to India. Welcome to India and enjoy India. Thank you. Let's shift to our next talk. If I invite the next presenter, Saimak Jairi. Not here. The next is topic is unpredictable outcomes post-phakic intraocular lens implantation. The chief presenting author is Garabita Dabas. You're there. Thank you for coming.
A very good morning, everyone. Welcome to my presentation of unpredictable outcomes post-phakic intraocular lens implantation. This is a case series of 4 cases where we had completely uneventful surgery and yet we were met with surprising outcomes. So phakic IOLs have shown promising visual outcomes, but they have their own set of complications and challenges that we're all aware of. And sometimes, despite meticulous preoperative planning and calculations, one may encounter unforeseeable consequences. My first case is regarding a 21-year-old female who complained of a suboptimal visual gain in the left eye post an uneventful surgery. So as we can see, her pre-op parameters were, she was 6'6", BCVA, refraction was high myopic, lens implanted was 8.5 diopter and -9 diopter. Post-operatively, there was the vision gain in the left eye was low, which was 6-9 parts. And after we did the ASOCT, we were surprised to discover the orientation of the lens was wrong in the left eye. So yes, due to the reverse orientation, we explanted the lens and re-implanted the new ICL in the correct orientation. The post-op vault was good, 575 microns, and follow-up is almost 2 years where the patient is been stable. She is still under observation just to avoid any early cataract formation, but yes, she's doing well as per today. My second case is regarding a 27-year-old female who again complained of less diminution of vision in the left eye after 2 months of uneventful surgery. High myopic, size implanted in both eyes was a toric ICL 12.6. Left eye, diminution of vision after 2 months was 6-9 parts. So we redialed the lens, we found it was misplaced, and after redialing, again the patient presented with diminution of vision, so she had to undergo again redialing after 3 weeks after the first dialing, followed by a second redialing almost 4 weeks later. So ultimately, we decided to explant the toric ICL and implant a bigger size ICL because there were already 2 failed redialing attempts. Post-op 6 months, the patient is stable with a vault of 435 microns. My third case is regarding a 23-year-old female who underwent again uneventful phakic IOL implantation with a good gain of vision. However, at 3 months post-op, she still complained of a high vault. She was high myopic with -13 with -2 refraction in the right eye and -15.5 with -2 in the left eye. Her parameters pre-op are all noted here. And as we can see in the ASOCT pictures, on day 1, the vault was 1120 micron. At 1 month, 1250 micron. And at 3 months, it was almost 1200 microns. So we were, yes, surprised why such a high vault. Is this acceptable? What to plan? So the left eye was kept under observation and the right eye was planned almost 3 months later after observing the behavior of the lens in the left eye. The right eye was planned with a smaller ICL, which was 12.1, as even against the manufacturer recommendation. And as we can see, the right eye vault was 691 microns, whereas the left eye thankfully maintained at 1200 microns. The patient is still under observation. Last case, the patient again underwent an uneventful phakic IOL implantation, both eye with a good gain of vision 6.6. High myopic patient, white to white was almost equal, 11.13 and 11.14 in the left eye. Remaining parameters were normal. However, post-operatively, we found the left eye had an extremely low vault of only 52 microns. So, to plan the left eye surgery, ICL exchange was planned with a bigger ICL. And post-op 1 year, the patient is found to be stable. This is post-ICL. This vault is still 136, better than 52 microns, even though we've gone with a bigger ICL. But we still keep under observation. There are more studies available in the literature where less than 250 microns patients have been doing well, and we intend to keep her under observation. So the patient is 2 years follow-up right now, stable vault maintained, and the patient is still doing well with 6/6 vision. I would like to finally discuss all my 4 cases. In the first case, there was a left eye reverse orientation of phakic IOL, and ASOCT proved to be a useful modality to correct our orientation. The second case where there was a left eye rotational instability where the lens was explanted and a bigger lens was implanted so that the toric ICL remained in place. The third patient had a significantly high vault for which the patient was kept under observation because the angles were open, there was no pupil diameter change, and such patients may be kept under observation. And in the last case, due to low vault, again, there is a risk of cataract surgery, cataract formation. However, low vault patients less than 250 have been reported to stay good, doing well under observation, so we intend to keep her under observation as of right now. Thank you.
Thank you so much,
These are my
Garvita.
references. Thank you.
You have not shown here your affiliation.
Yes, sir.
Your affiliation.
Center for Sight, sir.
Not written in there.
It was on the main. Sorry.
That means you're unknown. Just hold on. I think it is very important to learn that whenever you're putting your first slide, your name, your affiliation, your degrees has to be mentioned, That's a very important part for any presentation when you're presenting paper.
Right.
Okay. Did you learn something from these 4 cases?
Yes, sir.
So what did you learn for the first case where you implanted inverse?
So my personal takeaway is that the surgery of ICL may seem, the intraoperative part
No,
may
what
seem
did you
easy,
learn
but
because the lens were inverse? So what did you learn for that?
so post-op thorough observation and
Not
check.
post-op, it has to be intraop, no?
Intraop, we have to be careful, sir.
But careful. How do you avoid inverse implantation in ICL?
So proper loading, first of all.
How do you load it? What are the points to be seen so that you don't load it in a inverse manner?
So as if we talk about the ICL, there are markings that give us the leading haptic and the lagging haptic. So we have to make sure it's loaded well.
Where
And
should
even,
the marking should be?
sorry, sir?
Where should be the marking placed? Which side?
Which,
You
the
have
leading.
4, 4
Yes, there was
haptics.
4.
So
Yes.
where exactly the marking and where should that marking be facing?
So upwards and forward. Sorry.
You should learn further,
Yes.
ASOCT is too late. What would be better to judge these things?
First, the slit lamp
So
examination,
if you
sir.
have an intraop OCT, which many people have acquired now,
Okay.
I think, Center for Sight Dwarika now
Yes,
has
we
the
have it.
IOCT microscope with the silk procedure.
Yes.
That gives you, on the table you can assess and you can manage these cases. That is one. And many things to be learned. I think I have one question for there. Just one question, please.
Just referring to your second and the fourth case. First was the rotational instability and the fourth case was 52 volt. I mean, would you not have taken 2 sizes higher in the, especially the last case, because even after the second surgery it was 136.
Yes.
So were you mismatched in even the second calculation?
Sir, the other eye was doing well. So we had stepped up 1 size because we were afraid if we step up 2 sizes, we could land up with closed angles or any other complication.
You should have gone a 2 step, 2 sizes above.
Because the manufacturer normally would not allow you that. That's the major concern. The only thing which you have to learn is, your measurement has to be accurate. The white to white measurement has to be done appropriately. If you see the second case, the white to white was a 10.9 or something. It was smaller white to white. So
Yes.
you always have a difficulty there. So if you have white to white more than 11.5, you're going to have a difficulty there. So you have to have some concern, some your nomograms for these cases which are of the slightly away from your normal range. That is the learning.
Right.
But your name is, not like a Center for Sight, Garvita Dabas. Dabas?
Yes.
Dabas. Thank you for presentation.
Thank you.
Tip from you, sir.
Yeah.
What is the best way to measure white to white?
Look, it depends on your institution. If I have the facility, yes, we'll use so many things. The best is still the manual digital caliper done in a proper position. Patient should be lying supine and it should be measured under microscope so that you have an accurate adjustment. And second, maybe any other device which is automated. It can be your IOL master, it can be your pentacam, it can be anterior, anything. And these two measurements should be matching. Because one, if you suppose I go for a IOL master 700, I know that it is going to be larger than the manual keratometer. If always there is a difference of 0.5 or so. If that is happening, I'm sure that is correct one. And whichever you use should be your own hand, so that your reliability is there in the subsequent cases also. But people talk about, doing UVM to sulcus to sulcus. People talk about angle to angle by, high definition OCT pictures. All these things can be good assessment. Ultimately, the day will come where all these parameters are taken: AC depth, white to white, angle white to white, sulcus white to white, and the other parameters, the lens rise. These are all parameters should be included, and you'll have AI-based formulas to look into that. So that's a feature subsequently. Okay, thank you so much.
Thank you, sir.
Let's go to the next presenter, that is on comparison of anterior chamber iris fixated IOL and microkeratom assisted LASIK surgery outcome in Mongolian adults. The presenter is Narangarab Gonchin.
Sorry.
These are two different, wider things too. But your topic, we'll see the topic, don't worry. From Mongolia, topic can change. Coming such a long distance.
Yeah. Hello, everyone.
Yeah.
First off, thank you for inviting me in this conference.
The topic is different
Yeah.
than what is printed here.
My name is Narangarov from Mongolia, Solongai Hospital. This study was conducted under supervision of Mongolian National University of Medical Science between the 2022 and 24. Refractive error are common condition in the population and are of the 5 leading causes of preventable blindness according to World Health Organization. Presbyopia, a condition that affects the quality of life and reduced work capacity and productivity. We set 3 main objectives that can be seen on site. Firstly, we evaluated refractive errors who agreed to undergo cataract surgery. Then we estimated visual outcomes of patients who underwent different cataract surgeries. Lastly, the visual outcomes of monofocal and trifocal IOS. Sample size was calculated using formula above. This study was conducted using a retrospective cohort study design as we collected data from hospital database. At our hospital, cataract surgery was done, total 3,500 people for the 4 years. Of these patients who were included in our study went toward IOL calculation and appropriate lens IOS were selected. And those patients we follow up the first of 1 day, 1 week, 2 weeks, and 1 month. You can see the inclusion and exclusion criteria in this slide. We see it in our study. Then mean age results. Then mean age was 24, and with myopia 41, 7.87, and hyperopia is 51 in age group. The mean difference in age group was statistically significant, and a sex ratio of 2:1. Of all patients, 15.5 of the had low myopia, and 31% had moderate myopia, and high myopia was 63% of this. 69.06% had monofocal IOS, and 30% had trifocal IOS. The myopia group had twice as many monofocal IOS than trifocal IOS. No difference were observed between the groups in terms of refractive errors in type of surgery. And myopia group, the preoperative best correction visual acuity was 0.7, and the monofocal group, which improved the 0.5 on post-operative 1 day. And the post-operative trifocal diodes pre-op visual acuity was 0.3, which improved then 0.2 in post-operative 1 day. We use regression analysis to examine the above results. We examined whether the visual outcome after surgery differed the refractive errors types depending. In myopia group, pre-op near vision in the monofocal group was 0.9, while in the trifocal group it was 0.4, indicating that the near vision in the monofocal groups was weaker. In hyperopia, the pre-op near vision was 1, and the monofocal group and 0.5 in the trifocal group, indicating that the near vision was 2 times worse in the monofocal group. Now we're first off 1 month, and monofocal groups improved the 0.5, while the trifocal group improved. After 152 patients with the refractive errors, 80% were myopic, of which high myopia was at 68, and hyperopia was 19% in percent. And myopia and hyperopia group visual acuity improved in short period of the time after trifocal iris implantation. Thank you for attention.
Thank you so much presenting this series of cases where you have subjected the young patient to undergo cataract surgery. Your average age in the male for 34 and female 45. And you know, we have so many other options to correct this refractive error. We could have used phakic IOLs and preserve the patient's accommodation for a longer time. Trifocals might give you immediate, improvement vision, but in the long run, we are not sure because your follow-up is just few months.
Yes.
If you see these patients 3 years, 5 years, 10 years, the entire scenario would change. And doing a clear lens extraction in high myopes is always challenging. You had almost 18% high myopic patient in your group, and these are challenging cases for future also. You didn't have any complications?
No, it's only exclusion and
No. You can have a surgical challenges because to do a clear lens extraction in young patient can be really challenging. And to implant lenses and see these patients, especially trifocal lenses, they can have so much of difficulty in day-to-day activities. Driving can be difficult in young patients.
No any complications.
The pupil size is bigger. In Mongolia, you have so much of brighter light, and they can be having a tough time also. But I think, if you have access to phakic IOLs, you should use these phakic IOLs for these patients rather than making them, pseudophakic. That's another option. Any question? One question I'll take. Okay, thank you so much.
Okay,
welcome to India, and enjoy India for some more time. Let's come to next topic, that is correction of correlation of ball changes with dysfunctional lens index. Dr. Manpreet Kaur from RP Center, AIIMS.
A very good afternoon to all of you. I'll be presenting a study on correlation of wall changes with dysfunctional lens index and nuclear sclerosis after presbyopic phakic intraocular lens implantation. No financial disclosures. So the global unmet need for presbyopia stands at 45%. Surgical correction includes corneal ablative and lens-based procedures. Presbyopic phakic IOL is a potentially reversible and safe procedure to surgically correct presbyopia. We now have in the market 2 commercially available ones, the Star Evo Viva, which provides up to 2 diopters of extended depth of focus, and the IPCL by Care Group, which is a hybrid hydrophilic acrylic refractive diffractive design. So our purpose was to evaluate the refractive outcomes, Walt, dysfunctional lens index, and nuclear sclerosis after posterior chamber presbyopic phakic implantation. It was a prospective interventional study on 48 eyes of 24 patients undergoing IPCL implantation at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. The primary outcome measure was the uncorrected near visual acuity. The secondary outcome measures were uncorrected distance and intermediate visual acuity, Walt, dysfunctional lens index assessed by ray tracing aberrometry, and cataract formation with a follow-up of 5 years. Coming to the results, the mean age of the patients was 46.2 plus minus 3.7 years. At 5 years, the uncorrected near visual acuity was 20/40 or better in 75%. The uncorrected intermediate visual acuity was 20/32 or better in 100%. The uncorrected distance visual acuity was 20/20 or better in 100%. A significant improvement in total higher order aberrations and strain ratio was observed after presbyopic phakic implantation. The mean immediate postoperative Walt was 571.2 plus minus 241.2 microns. The Walt decreased to 342.8.7 plus minus 179.2 microns over 5 years with a significant p-value of 0.001. The dysfunctional lens index decreased from 8.38 plus minus 0.89 to 6.32 plus minus 1.21 with a p-value of less than 0.001. The decrease in Walt correlated with a decrease in dysfunctional lens index with a Pearson coefficient of 0.221 and a p-value of 0.027. Intraoperatively, inverse phakic implantation was detected in one case on table using IOCT. It was explanted and re-implanted in the correct orientation in the same sitting as well with no further long-term complications. Postoperatively, nuclear cataract formation necessitated phacoemulsification with phakic removal in 20% of our eyes, 6 out of the 48 eyes. The mean time to surgery was 22.3 plus minus 13.2 months with a dysfunctional lens index at the time of surgery of 2.1 plus minus 0.63. Just to highlight the case, there was a progressive increase in higher order aberrations with development of cataract at 1 year. So on the left hand side, you can observe the 1 month ray tracing aberrometry with acceptable higher order aberrations. These significantly increased for the total eye and internal, which correlate with the lenticular aberrations at 1 year. There was a progressive increase in dysfunctional lens index at 1 year from 5.56 over here to 3.49, progressive worsening. So just to conclude, the presbyopic phakic provides spectacle independence for near in 75% of cases, which is 3/4. A positive correlation was observed between the decrease in Walt and dysfunctional lens index over 5 years. Nuclear sclerosis requiring surgery was observed in 20% of cases within the initial 2 years, which was associated with a decreased dysfunctional lens index. So phakic have been proved to be safe and efficacious in the younger age group for the correction of myopia and hyperopia. For presbyopia, they do provide a functional near vision. However, the age group is different from the ones undergoing refractive surgery conventionally, and there is a significantly higher incidence of earlier cataract formation in these cases. Thank you for a patient hearing.
Thank you so much, Dr. Manpreet, for a nice presentation. Any questions from the house? Dr. Ang?
So by appearance in the slit lamp, you differentiated the cataract to nuclear instead of the touching in terms of anterior subcapsular.
Because the touching would be, the location would be subcapsular, the nuclear would be in the nucleus.
Be differentiated in the eye trace. So just the slit.
Yeah.
Yes, on a slit lamp, yes.
These cases are more of a nuclear sclerosis, all of them, which is seen and slowly progressive and induction of a higher order aberration in these cases. We didn't have any cases with the subcapsular opacification in these cases also. And I think, these are good alternatives, but ultimately these patients will have early cataract formation because we are putting something, which is not clearly physiological. Thank you, Dr. Manpreet. Let's move to the next speaker. Dr. Sonu Goyal is here. I think he's not here, so I'm going to invite my dear friend Robert Ang, who's going to talk about 1-year clinical outcomes of two different ablation profiles, regular and strong, with the supracore presbyopic LASIK treatment.
Good afternoon. Thank you for accepting our free paper on SupraCore, which is one of the presbyopic LASIK options with the Bausch & Lomb Teneo 2 M2 laser. So I'm an investigator for many companies doing presbyopia treatment, including Bausch & Lomb. So LASIK, as we know, patients come for laser surgery, and they mean LASIK, and when they're above 40 years old, then you need to make a choice. Do I use monofocal type of LASIK and do monovision, or does my machine offer me a presbyopic LASIK option? So the SupraCore is an algorithm that creates an ablation profile where the center is steeper. So the simplest way of describing it is a controlled central island in the middle, which is elevated in the central 2 millimeters and flatter in the periphery. So why is that? Because the center, when your pupil constricts for accommodation, you want to be looking in that central zone for near vision, whereas when your pupil dilates, when you look at far, you want the mid-periphery to give you the good far vision simultaneously. Okay? So over the past 10 years that I've been using this, we had one program, we call it SupraCore Regular, or the regular SupraCore. But for the past 1 to 2 years, an innovation in an algorithm created a mild, regular, or strong. And in this study, we are comparing the regular, which we started with the new stronger program, because we wanted to know if it can give better near vision. So as you can see in the topography on the left, the SupraCore Regular creates this steep zone, and the SupraCore Strong creates an even steeper zone. But everything else is the same in terms of targeting and refractive outcomes. So in our study, we recruited patients. They were either myopic or hyperopic presbyopes, and we randomized them. My technique in presbyopia treatment is modified monovision, meaning I want to make sure the dominant eye is good for far. So we use ProScan treatment. The non-dominant eye will be good for near, but with good distance as well. So that gets SupraCore. So the non-dominant eye in the study will either get a SupraCore Regular or a SupraCore Strong. That's the randomization we chose. So we have these tests and 12 months follow-up. So in terms of baseline characteristics, so 48 to 50-year-olds were included in the study. Then more females, of course, more females. Photopic, uncorrected distance vision here on the left shows that uncorrected distance vision is 0.14 or 0.16, which is about 20/25 or 20/30. And near vision, uncorrected near vision is also 20/25. So whether it's strong or regular, it gives good distance, good intermediate, uncorrected, and good near vision. Now, one of the things that are evaluated in presby-LASIK treatments is, does the algorithm cause loss of lines of vision? And because of the improved smoothness of the profile, none of the patients lost 2 lines or more. So when you have previous studies, they show that they lose 2 lines, but now no more. The focus curve shows a smooth, a continuous range of vision, and in terms of photopic and uncorrected near vision, you see this good distance, intermediate, and near vision. In terms of MRSE, the target is minus 0.5 to minus 0.75. So at 12 months, the SupraCore Strong is a little more myope because of the added steepness, but 0.7 versus 0.5 in the SupraCore Regular. So we are on target in terms of refractive outcomes. Now, how independent were they in terms of glasses? Distance, intermediate, and near. Near vision is about 85%, distance vision is about 90 to 96%. So in terms of outcomes, first, our strategy of one eye distance proscan and suprachor on the other eye works very well. Patients are happy, and both algorithms are showing good efficacy and satisfaction. Thank you very much.
Very nice outcomes. Any questions? Because to have such a long-term outcome, is really good.
Yes.
5 year plus in this thing. Do you have a experience with Press Beyond also?
No, usually doctors will either have one machine or the other. Rarely will somebody have two different brands. They're quite expensive.
Because what I've seen, people who practice these, right, Technolas, they are fan of Suprachor, and
Yes.
people who have Mel, they'll say, okay, Press Beyond is better.
Yes.
Both works on a dominant, non-dominant eye fashion in such a manner where distance corrected with the dominant eye and near with the non-dominant eyes.
Yes.
It seems to do well if you correctly choose your patient and counsel them appropriately.
Yes, and the dominance testing is very important. You cannot be wrong in the dominance or else.
Absolutely correct. Any regression happening in the long run in these cases?
Usually, I tell my patients that this lasts about 5 years because they will progress in terms of presbyopia. So the refraction is still the same, but now they need more reading. And when we track them over time, so I have 8 years patients already, the refraction still minus 0.5, but they became more presbyope. So the non-suprachor eye became worse in terms of reading. So now they feel that, I want reading glasses.
Okay. So can you add on to that some additive procedure?
Yes, we had our experience with retreatments wherein we added more minus in the suprachor eye and made them -1 or -125 because that's their age. So when you're 52, 55, you need more.
Yeah. Thank you so much.
Thank you.
Let me invite the next speaker if they are there. Changes in binocular corneal innervation and binocular imbalance after unilateral smile and TPRK. Chief presenter is Liang Hu. Next, Thomas is not here. Thomas Conan. Please, you are here. And he's going to talk about safety and efficacy of customized photorefractive keratectomy treatments, followed by corneal cross-linking in patient with keratoconus. Yeah, please come this side. Thomas is a very well-known refractive practitioner in Europe. He's been a president of EACRS, and we are proud that he's come to APO AIOC this time in New Delhi.
Thank you. Thank you for the kind words, the nice introduction. Okay, I will have two talks, and one is basically on the photorefractive keratectomy treatments following by cross-linking. So you know that cross-linking was actually introduced 2000 in Germany and Dresden with Theo Seiler's group. It's a paradigm shift in keratoconus management over the years. And you can see that the publication was in 2003. They started this, but they, described and introduced it 2003. It's a minimal invasive and safe method for whole progression in keratoconus, which is, it's a treat for those patients who have a keratoconus. We're happy that we have that. You know, the principle is riboflavin catalyzes the photosensitization in cross-linking treatment, production of single oxygen, and then the reaction of singlet oxygen with nearby groups in corneal collagen fibers and protoglycans actually producing these stronger bonds in the collagen after the treatment. So we have enhanced biomechanics. Here's a paper, Evidence of Focus, pioneering studies on PRK plus collagen cross-linking. The reason is when you have these patients, you only cross-link them, they still see not very good because they still have the cone. Now we're all searching for something to help them even further. That's a pioneering work, prospective interventional, non-randomized clinical trial, 17 patients, 34 eyes with progressive keratoconus, whereas 17 eyes got PRK plus cross-linking. And here you can see the outcome in comparison. Evidence in focus pioneering studies actually showed that you can get better outcomes in terms of visual acuity if you put some evidence of PRK on top of it, so to normalize the cone. I will show you one patient. We have like several ones, only a small series. It's a 40-year-old patient, female, history of keratoconus, initial diagnosis when she was 21. The refraction was plus 2.25, minus 5.5 in one eye, left eye with 7.5 diopters. And without correction, she was 0.3 in both eyes. With correction, she was quite good, 0.8 to 20/20 in the left eye. So here you see the corneal topography with the oculus pentacam measurement. You can see on the upper left side the power map, and you can see the posterior map up right there, and you see typically the lower cone here. So here is the laser profile which we have used. This was done with a Schwind Amaris laser. I consult for both companies, for Oculus as well as for Schwind. And you can see here the laser profile. Rules for ablation profile is according to the Essence protocol, our colleague from John Kanellopoulos. Maximum ablation on conus is less than 50 microns. That's very important. And the residual corneal stroma thickness should be above 400. That excludes a lot of patients to do this. Because what we don't want to do is we don't want to take a cone, ablate him, and let it get worse, and then you anyhow have to do a penetrating keratoplasty. So this is a profile. This is the pentacam post-op. There is some regularization of the patient. Here you see the flattening above the cone. If I do the difference map on the right, post versus pre. And here are the outcome of basically 5 patients. So we have a small series. If you look at the outcomes, you basically can see that the post refraction has a reduction in 4 out of 5 cases highly. 4.5 was left here, but he had 7 diopters of astigmatism. And you can see that the visual acuity actually increased in most of these patients. Best corrected visual acuity did not decrease, and we had 20/20 in almost all these cases. So in summary, the cross-linking caused a paradigm shift in conus management. PRK and cross-linking might be the next step for corneal stability plus better refractive outcomes. With this, I would thank you for your attention.
I think that's a very exciting area, no, to have a customized cross-linking in these cases of keratoconus. I think if you look into last 2 decades of management with cross-linking, things have changed so much, and the requirement of surgery like DALK has really gone down in these cases. And we pick up these patients early and manage them, very good effect. Any questions for Conan? Yeah.
Yes, these are all topography-guided ablation zones, which we really meticulously measure and calculate. You can do it with a software. We do it with the company because we really take that 50 microns, 400 microns. If that doesn't fit, then I don't do the treatment because it becomes too dangerous. It's also in my country, we have this as a limit range of indication for conus treatment. I think the jury is still out if they hold for a long time. We don't see a 10-year follow-up of these patients, so let's see. We're just investigating on these patients. They know that. No, you cannot do non-topographic because you have to customize your treatment. If you do a normal laser treatment, you basically take away 20, 30, 40 microns all over the cornea. What you have to do is you need a topography guided because you have to selectively, ablate tissue. You cannot do it with a non-topography guided excimer laser. Not possible.
Okay, thank you. Let's go into next, your second talk, which is on IULPA calculation of
Yeah.
the DOF lenses following myopic LASIK.
That's also an interesting topic. May they help me here? Can you put next presentation?
Next presentation, please. It's not there?
Oh, now I have to go to the other?
I don't have any PPT, or you have on PPT on pen drive. I will upload it.
I've uploaded all of them.
I don't have received this one. क्या? नहीं देखो.
I uploaded yesterday all my presentations.
I have only one. This one.
Okay, could you give me, could we take the laptop? No.
We can take laptop.
Yeah? Give me a minute.
Yeah, sure. You can have very nice session here, range from the, if you look into a press myopic corrections, we had a very nice talk from Robert Ang, and we looked into phakic IOLs. We had two talks on the phakic IOLs. One was, press myopic phakic IOL. One was a routine implantation difficulties in ICL type of things. Then we looked into something new where people look into early lens exchange surgeries for a refractive error in a country like Mongolia. Then we also looked into post-residual refractive error corrections by various means, post-cataract surgery, post-LASIK, and those, smile lenticule, creating a smile they are challenging, but people are working on those areas also. So we had a wide range of covering these topics. Any question there? Yeah, please. The idea of entire treatment of keratoconus is, to make the collagens more compact and stronger. If that happens, the thickness will be, taken off into consideration. If I have a 300 micron thick cornea, which is stronger, that's going to work better than a 500 thickness cornea, which is not stronger. That's why the studies we are now looking into actually looking into biomechanics of these corneas. How stiff are those corneas? Stiffness of a cornea is important to look into. If we do a cross-linking, we are making cornea stiffer. And that's how it's going to prevent the further ectasia happening in these cases and prevent the, whatever outcome we have achieved in this. And you're right, if you do a PRK in those cases, we are taking out some more tissue in this. But actually, this customized PRK doesn't take out many larger amount of tissue in these cases because it's a topo-guided treatment. It takes in those areas where actually you treat. And combining with cross-linking, definitely yes, it's going to have more, compactness in the cornea. That's the only thing we look into. And if you take up cases early where you have a cornea thickness 400, 420 or 450, you are going to have better outcomes in these cases. If you do this treatment is in 280, 290, it's not going to work.
Even with cross-linking alone,
yes.
without having done a PRK.
There are few percent of cases which might progress in the long run. That depends on what type of procedure you have taken. If you have taken a proper Dresden protocol for 30 minutes ablation, this works best. But in recent time, we have shifted to a different modes of management, which may be accelerated cross-linkings, which doesn't work as effective as, the proper Dresden protocol. So those things has to be assessed also in these cases. There may be other compounding factors also, physical factors. Eye rubbing is one of the important factors in progression of disease, despite cross-linking also, or associated inflammation. Because we know that inflammation, one important component in increasing the keratoconus, or maybe one of the factor for a keratoconus happening, or subsequently also. 2-3 things. I think Thomas is ready now. Can
Yes,
you make
I'm
a
ready.
presentation?
Thank you, the team, to help me. Okay, so the topic is really, you know, accuracy of IOL calculation in non-diffractive and diffractive lenses after LASIK. Because you all know that you have a problem in calculating the IOLs after these patients. So the background really is many patients are now with a history of, you know, LASIK. They come to our clinics and want to be treated, and these are the patients who want to be spectacle independent because they had refractive surgery 30 years ago or 25 or 20 years ago, and now they want to be spectacle independent. They can be after refractive lens exchange or for refractive lens and for cataract. Challenging IOL calculation. Post-operative dry eye is common in these patients, and EDOF may be a solution. So what we did a study where I'm just showing you minus 2.5 is different from minus 8.5 in terms of flattening of the cornea. So we decided to go for EDOF lenses in most of these lenses. As a side note, I'm also doing multifocal lenses if the corneal higher order aberration in these patients are low. So you can have a patient coming into your practice and says, I post LASIK. If he has -2, he might be a good candidate for a multifocal lens. But the multifocal lens, the problem is you have not only the calculation error, and if the patient is optically aberrated with a bad cornea, multifocality might not be great. On top of this, you have to achieve emmetropia, and if you cannot do this, you don't have a good outcome. You may have to exchange the lens. So we looked at the lenses, and we're using most of the time now non-diffractive EDOF rather than diffractive EDOF lenses. And our data here is a 53 eyes of myopic patient after LASIK between -1 and -6. This is a cohort of 2 papers. One paper is already published in Journal of Refractive Surgery. These were actually 2 different diffractive IOLs. And then we have now most recently added 34 eyes of a non-diffractive, and that's a wavefront shaping IOL, which we have used. The preoperative measurement were Scheimpflug imaging and ray tracing. These are the lenses we have in this study. One is a diffractive lens from J&J, the Symphony. One is the Acrylara from Zeiss. And the second, the non-diffractive, is the Vivity from Alcon. And here are the outcomes in total, in general. You can see there's a box plot, verification of the outcomes, box plot determination. And you can see at the bottom, you were on the left side, you're very close to 0 with the various formulas. These are the most used formulas in the world now with EVO, the Hoffer, the Pearl, the Barrett formulas. Here is the outcome plus minus half a diopter, and you can see most of the time the Potvin-Hill-Chammas is very good in terms of outcome. I'll come to this in a minute. This is the subgroup of diffractive IOLs. Same thing, I will conclude this. You can see here from a quarter of a diopter, half a diopter, 3/4 of a diopter, 1 diopter. Of course, 1 diopter always brings you to a very good outcome. With the best formula, we had 47% below half a diopter with the diffractive IOLs, 79 with 1 diopter. So you still have outliers. This is the group of the non-diffractive lenses. Here is again the subgroup analysis. And what we got here is half a diopter in 74% and 1 diopter in 97% of the patients. So this is a summary slide. The distance visual acuity with correction was in both groups very good, close to 20/20 with an EDOF lens after LASIK. The distance correction without was not as good. And you can see the diffractive is worse, and the reason is that the outcome in terms of getting it to 0 was less predictable. We had 47%, I repeat, in the diffractive of a half a diopter, 79 for plus minus 1, in the non-diffractive 74%, and 97% plus minus 1 in this lens. Now the next step is of course to look at the optical quality, but that's a different issue. So the summary of this talk is the calculation of IOL power after LASIK remains a challenge. Normal cataract surgery, usually 70 to 80% plus minus half a diopter, maybe 80 to 90. That depends on what you have. But you can ask yourself, what is my prediction error after cataract surgery? Do I achieve half a diopter in 90% of my patients? That's usually not true if you really look at it. And this is determined by high myopia as well as high hyperopia. A 20 diopter lens is usually a no-brainer. But if you have a 33 diopter or a 10 diopter or even a -5 diopter, then it becomes more complicated. The hyperopes are more complicated than the myopes. Our study determines, 59% plus minus half a diopter. The predictability of IOL calculation is reduced. After LASIK, refractive surprises can occur with any formula. Therefore, my preoperative patient counseling is very essential. I always talk with my patients post-LASIK about an early IOL exchange. If I really miss the target, I tell the patients I change the lens, because I think that's the way to go rather than to another corneal procedure. Thank you.
Thank you so much. I think this is the challenge for all of us to have some formula which will be more accurate. And whatever we do in the post-refractive surgery cases, we do have the target which is little off. But look into this study. There's so many formula has been used. I think gives you an idea that you have to have your own thinking to subject your patient in such a way that you get the best outcome. If you look into, Thomas, if you look into your routine patient, non-LASIK patients, which formula do you use for routine cataract patients? Which is your go-for formula?
Well, I don't think that we have one formula to go. We actually calculate with the most modern for the EVO, Barrett, to universal, also the formula which takes into account the posterior curvature. And what we now do is since a year, we have the ESCRS formula, which is different from the ASCRS calculator. The ASCRS, AP-ASCRS calculator is specifically for post-LASIK eye, for post-RK eye. That's not what we're looking for. We're looking for the normal cases. And in the ESCRS calculator, you find it on our website, you basically have all the formulas. So you punch in your data, and then you get the outcome of the Barrett, of the Pearls, of the EVO, of all the new ones, the Potvin, and then you can really differentiate for yourself and make a selection. Usually they're very close with what we get with Scheimpflug Pentacam or with the IOL Master 700, very close, but we usually check. And the reason is I do 90% presbyopia correcting IOLs, and there, for example, in a multifocal lens, I have to achieve emmetropia. Otherwise, I have to exchange the lens. So my goal, not only my goal, my wish is it, and my, all effort goes into IOL calculation, because that prevents IOL exchange.
Thank you so much. Yeah.
So you were implanting refractive IOLs, the EDOF ones and the enhanced monofocal. So they are to provide something in addition to this too. So I would be interested in knowing what were the new and intermediate visual outcomes.
Can you go to take the microphone? That's hard for me to understand.
So what you implanted were the EDOF and the enhanced
EDOF lens, yes, a non-diffractive EDOF in the second part, which is my standard of care at the moment. I don't do post-LASIK diffractive. I actually have stopped diffractive EDOF lens. So I don't think it's a good, I usually rarely use it for the high myopes.
So what were your near and intermediate visual outcomes with these formulas?
As I told you, this paper was only on the prediction. But I can tell you that the outcome in intermediate with these lenses are pretty good, but they are not reaching, let's say, a useful near vision, but they need glasses, +1. Okay. So we don't tell them that there can be spectacle independence. And that's important. It's a very important question. We tell this to our patients, and many of them come, Professor Kuhn, can't you put a multifocal lens in my eye? Then you look at the cornea, it's 10 years, 20 years with a small optical zone, 4 millimeter post-LASIK, -11 diopter. I dare to put a multifocal lens, even if the patient wants that. I don't do it. I tell him, you unfortunately have a cornea which is not working properly anymore. Sorry, because my colleagues, or maybe we did it 20 years ago, but at this time the lasers were not so perfect. So now, in order to make you as most spectacle independent, I predict, or let's say I propose a non-diffractive EDOF lens to you. That's the best you can have. If you talk about monofocal plus, you can also take a spheric monofocal lens. I think the whole, this enhanced monofocal business, in my opinion, does not bring me any further, because I have seen studies on aspheric monofocal lenses which achieve the same outcome than an enhanced monofocal lens.
Correct.
So I just wanted to know.
Yeah,
that
okay, last question.
So the
Can you
comparison between
put
the
the
two-
microphone? I cannot hear.
The comparison between the two groups. Why do you think there was a difference in the in the uncorrected visual acuity? Because both the groups must have been aimed for emetropia. So
Well,
simply saying that
it's a little bit unfair for us to judge it, because we put this together. Actually, you know what happened is, we had published the diffractive lenses 2 years ago, and then we had the non-diffractive, and then when we submitted the paper, then the reviewers asked us to compare it to diffractive lenses. So then we said, okay, we go back to our previous method. We took it with the same method as we have now, and now we're coming to these outcomes. I don't know why, but with the diffractive lenses, we just don't have as good results in terms of
the
predictability.
general understanding that diffractive, non-diffractive lenses are more forgiving. That is all, like the kind of.
The non-diffractive are non-forgiving?
Non-diffractive
More
are
forgiving.
more forgiving. That's what is the takeaway.
That's a good question. I think we have to differentiate between IOL calculation, achieving emetropia, and visual outcome. That's two different boxes.
Okay, thank you so much. Thank you, Thomas, for your last inputs. We conclude this session. Thank you for participating in some discussion of importance, because these presentations are not only meant for a presentation from a presenters, also it is meant for a discussion from the people sitting here. Thank you for that, and see you immediately after a break of 15 minutes to the next session here on cataract refractive. Okay, anybody who are keen for a photograph, please come.